Hi, this is Brad, and this is my submission for the peer competency case study number 2. I'm going to share my screen. Okay, so my primary hypothesis for this case was that this patient is having some sacroiliac joint dysfunction. Some of the evidence that I'm using to support that is the location of the pain she's having. It says left posterior thigh and low back in the paragraph. In this picture, which isn't showing up, there was an X marking the location of the pain, kind of in her, I think it was like the more left side, lower back. So just going with that lower back area is kind of where the sacroiliac joint would be. So, and then she's having pain with bending over and lifting. So possibly when the sacrum is going into counternutation, that could be which is happening when she's bending over. That might be part of the reason she's having pain. And then there is a possible mechanism for her pain from her pregnancies, which could have caused some stress on that joint, and then getting exacerbated with physical activity such as playing soccer. In order to rule in the sacroiliac joint and rule out other parts of the body, so first ruling in SI, doing the cluster of tests, starting with the posterior thigh and distraction. If the SI is involved, we be looking for positives with those reproduction of P1, and then continuing on if we need to with the compression and sacral thrust tests, and if needed. If we need more testing after that to kind of confirm our hypothesis, you could do some observation during functional tasks such as squat and sit to stand. We could observe pelvic symmetry and palpate with the stork test, or when she's bending over, where we would expect the pelvis to move with that. And then if we do find positives with those, could assess the sacral mobility by providing anterior, posterior, or rotational pressures. So to rule out lumbar involvement, you can do active passive range of motion, looking for a range that's within normal limits and a capsular end feel without provocation of P1. Also, we could do the prone instability, which might be good to do if she's having pain with lifting. If there is some instability in the spine, that might cause some problems for lifting, but to rule it out, we look for no change in symptoms with the prone instability test, whether her legs are down off the table or when she's lifting them up. It would also be good to look at the radiographs that she had from her doctor's visit or whatever that's from. I would also need to screen for hip involvement, and to rule it out, we'd also be looking for normal ranges with capsular, possibly muscular end feels, which would be normal for some joints. And then, again, no provocation of P1 with those ranges of motion, and also the Fader and Faber tests. So some things that I might predict to be issues for her are pain with lumbar flexion. Again, the sacrum would be going into counternutation then, possibly extension, like the sacrum would be going into nutation. And then to manage those, I could employ some manual therapy techniques such as posterior innominate mobilization. These techniques and my answer for part 4 were mainly taken from this randomized control trial by Najati. Not sure if I pronounced that right. So going forward, the picture that they had in this article, the posterior innominate mobilization looked like the posterior thigh thrust that we did in lab. And then they also did an SI joint manipulation. So I I could do those if I do find that the SI joint is hypomobile. Um, some other things you might have problem with is ascending, descending stairs. One thing that the authors did in this article was stretching for the SI joint. They did some contractor lacks with the hip flexed, abducted, and externally rotated, and overpressures were provided by the therapist, and they did that 5 times a day. And then, as it said in the paragraph, she might have some troubles with playing soccer, and for that, I might use some spinal stabilization exercises, which these were very similar to the stages that we looked at for lumbar stabilization. So things like abdominal draw in, bridging, and bird dogs. And so those more functional activities I would maybe save later in treatment after we get the sacrum moving more as it should be. So then lastly, plan of care. The patients in this article were seen once a week for 12 weeks, which I think would be appropriate. I don't think this patient would need to be seen as frequently because it doesn't seem like she's very irritable. It doesn't seem like her symptoms are limiting her ability to carry out activities of daily living. It just seems more annoying, like the symptoms are just annoying. So I think a lower frequency once per week would be fine. If she was more irritable, maybe bumping that up to 2 to 3 times per week for 6 weeks. So then interventions would include manual therapy, so those mobilizations that I mentioned earlier, to get the sacrum moving better, and then therapeutic exercise, adding in neuromuscular re-ed with those exercises to hopefully educate the patient on how the sacrum moves during lumbar flexion, extension, hip flexion, extension. And I don't know if we are still required to do this, but just to be safe, just in case we are, I do think this patient is appropriate to be seen in physical therapy. I don't see any major red flags, although I might want to take a look at those, or I would take a look at the spinal radiographs just to make absolutely sure that there's nothing too serious going on in the spine. Okay, so I'll stop sharing. That is my submission for case study number 2. Thanks.